Hi. So we're going to get started this semester on the cervical spine. If you notice there's a giraffe in our very first slide here. We just want you to think about how many neck vertebrae there are in a giraffe as compared to regular humans, which will be answered at the end of this PowerPoint. So the vertebral column, as you already know, makes up the spine. It's also known as the spinal column. Provides flexible support for the trunk, head, while also transmitting the weight of the trunk and upper body to the lower limbs. So it transfers a lot of the weight, so it's not putting too much pressure on any one particular view. You'll notice that there is a lordotic curve as well as a kyphotic curve, just to kind of balance out the spine. It's not one big straight vertical structure like you see here, but it's more of a gentle angling of the body, and they all kind of fit together to disperse the weight a little bit more. There's four basic curvatures divided between the areas. You have four areas. You have the cervical, the thoracic, the lumbar, and then the sacral spine at the end. Cervical and lumbar are lordotic, which are classified as concave. So both of these, you notice, are going in the same direction, so they're both considered concave or lordotic. Thoracic and sacral are just different. Those are going to be considered convex, and they just kind of balance each other out, going the opposite direction as the lumbar and cervical. The first compensatory curve is the cervical. First primary curve is going to be actually the thoracic. Second compensatory is considered the lumbar. Second primary is considered the sacral. So if you just remember CP, CP, it'll be very easy to remember the numbers and which ones are associated with each. Starting with the cervical spine, you have 7 vertebrae that make up the neck. Vertebral column will be rigidly immovable without the intervertebral disc and zygapophyseal joints. So there are a couple of joint spaces that you're going to see that makes it able so that the spine is able to move around. It's considered an amphioarthrodial joint movement between the vertebral bodies. Your first intervertebral disc spaces are going to be between the bodies, basically here, here, going all the way up until you get to C2. Zygapophyseal joint spaces, however, are going to be these little diagonal spaces that you see here between each one of these vertebrae. So there's a couple of different joint spaces that you need to be aware of. The atlas and axis are going to be the first and second vertebra. They are much different from the rest of the vertebra, 3 through 7, so you need to know the different structures on them and how they look a little bit differently from typical cervical vertebra. Atlas, most superior vertebra, looks very different from the rest. It's more circular than any of the other vertebra. The basically foramen, where the spinal cord goes through, is a little bit bigger. You have these facets on here on the condyles where the head actually kind of rests on with the skull. You have an articular facet for the dens, so you have a little smooth area on here that actually articulates with this, the C2 part of it. You only have very small spinous processes on this one as well, so the little kind of tail at the back of this spine or vertebral bone is going to be very short on the C1. It's going to articulate with C2 going inferiorly, so you have a little bit of a smooth part. Facets are really just smooth parts where other bones kind of connect into it. The dens of the C2 protrudes upwards through the opening of C1. We'll show this better on some of the other slides that we have going up and down here, but the dens does project upward into C1. So just a top-down view of it here, kind of a cross-sectional land. We look at it. Cervical vertebrae are going to have the foramen, transverse foramen that you don't see in the thoracic or the lumbar spine at all. This is going to be for passages of the vertebral arteries that go from the heart basically up into and supply the blood flow to the brain. You have several different areas that are typical of most vertebra. You'll have the vertebral body, which will be the thick, kind of easiest part to see on this, as you see here and here as well. What's going to happen after that is it's going to form basically this ring going around, which is where the vertebral foramen is. This is where the spinal cord is going to travel through. So this ring is composed of several different parts here. The very first part, this little strut that comes right off of the first portion of the vertebral body, are going to be the pedicles. So you have a pedicle on each side that kind of makes up this little area. So when you look at this in an oblique angle, looking this way, it's going to look a little bit more circular. You can also see it on the AP axial pretty well. As the circle goes out to the outside, you have the transverse process. So you have this little thick portion of bone that goes sideways, basically. That's going to make up kind of this middle portion of this circle. The lamina is going to be the second portion, or the posterior kind of strut when you're talking about this kind of hole going through here. The back portion is made of the lamina, site of particular injuries, potential fracture site as well. As these laminas go into completing this circle here and we go towards the end of it, we have the spinous process at the very posterior portion of the vertebra. This is just going to show you a few different looks at it with the actual bones. Kind of go through these a little bit. Main vertebral foramen is going to be a little bit bigger. This is of C1, so it's going to be much bigger on this one than the rest. Another thing I could tell you that's a little bit different is that superior articular facet on the lateral mass is going to be a little bit bigger on C1 as well, because the skull actually rests on this and pivots on that surface. C2, looking from the top down on there, you can see the dens, the little portion that's going to stick up here. It's going to protrude into the vertebral foramen of the C1 atlas. Pedicles will be the same. This is going to be considered the body right through here, so pedicles will be in this area here. You have a very short transverse process along the outside on C2. The spinous process on the posterior section is usually bifid in shape, which means there's going to be like two little points on there instead of just one smooth point like we would see on the C7 vertebra. This just shows C2 also, but looking from the back, looking forward, so you can see that little bifid tip we talked about on number 7 there. See this little tip here where it has 2 instead of just 1 on there. But you can see that it protrudes up into C1, and C1 is going to fit right over the top of that. So just showing the two connected together, kind of looking top down. Take a look at that. Look at the transverse foramen, which are in the transverse processes through here. This is where the arteries are going to travel through again, like we mentioned. C4 through C7 looks a little bit different. Everything is pretty much the same in terms of the shape, though. You have a lamina on the back here, the vertebral foramen in the middle. You have the pedicles right through here. You can see the transverse foramen pretty well. These little points here, these are just going to be the articular facets and the inferior articular facets of the vertebra, because they all kind of stack on top of each other. Body, it's going to be on the front portion that we talked about, the vertebral body. Vertebral arch, just that ring or arch that extends from the body, forms that circular opening that we mentioned. This just goes through what I talked about earlier with the pedicles, laminae, and transverse process and spinous process on there as well. If you look at this, what's interesting is if you look at C1, it does go out a little bit more wider than the rest of the vertebra. So when you're looking at this from the AP perspective, like you're looking at it here, you do need to make sure that this is on that particular view. Or if you're doing the odontoid view, you have to remember that it goes outside of C2 a little bit more. Spinous processes are bifid tip from C3 through C6, so that little tip that you see here, this is a bifid tip. This is a single tip going through here. Vertebral foramen is for the passage for the spinal cord, so the spinal cord is well protected, embedded within this bone, kind of protecting it going all the way across. Transverse foramen for vertebral arteries, certain nerves pass through, so those are these points right here. Intervertebral foramina are best visualized on obliques and is also a passageway for nerve roots. So on a lot of the nerve roots you do see them on the obliques. What you also see on these typical vertebra, the superior articular process and an inferior articular process. These little stacking bones create the intervertebral foramina that we'll talk about with the obliques in just a short bit. Inferior articular processes, it's down here, both form articulations between the vertebra. This is just another diagram, kind of looking from underneath it a little bit, so you can see a little bit different perspective on this view. Dressing instructions, I've covered most of it, but remove bras, shirts, collars, buttons, any metal around the neck area, those bulky seams. If they have double stitch seams around the shoulders, sometimes those show up. No earrings, especially on the lower lobe. Hearing aids, clips, bobby pins, glasses, because the metal kind of goes past the ears. You can see them on the lateral view. No rubber bands as well. They're okay on the lateral, but once you get past that, you shouldn't have that on. Necklaces obviously need to come off, anything similar to that. Nothing in the mouth can be taken out, including gum, mints, cough drops, tongue rings. Tongue rings should come out because it will show up on C1 a lot of times. Metal partials, retainers, anything with metal that pretty much needs to come out. Any unfinished food, either need to spit it out or finish chewing it. If they have dentures, if they're plastic, they do not need to come out. But it may be easier for you to see C1 and C2 if they do take it out. Lines of the cervical spine. These are just reference for the radiologist to identify any abnormalities. You have an anterior contour line that goes along the front of the vertebral bodies. You have a posterior contour line, which just goes along the posterior section of it, obviously. And the laminospinal line basically goes from the lamina, dividing that into the spinous processes. If anything is a little bit off from these, they can tell that there may be some kind of herniation or possible fracture. Positions we're going to cover: lateral, apiaxial, apiodontoid, and the obliques going both ways. Alternates, swimmers, we'll get into that. Fuchs or Judd is a good way to see the dens. Wagging jaw method, just for information's sake, and the AP pillars view is another view on there. If you look at this slide, take note of all the anatomy on here because there is quite a bit of anatomy going through here. You will need to count 1 all the way down to C7 as well. So 1 will be a little bit different, as well as 2 than the rest of the vertebra. The vertebra from 3 through 7, pretty easy to see. But 2, what's really different about 2 is it has dens sticking up into C1, and it also has this big old huge spinous process that's a little bit bigger and flatter than the rest of them. C1's pretty easy to see because it has a very small kind of rounded area going all the way across on here, so a little bit different than the rest. This is just showing some more anatomy, so go through that as well. That would be probably pretty helpful. Starting with the lateral C-spine, this is the most important view. It must clear in trauma cases, so if a patient comes in with a car accident, they are going to want to clear the neck with a lateral view just to make sure that everything is in order, that if you move the patient, they're not going to be paralyzed or have any significant abnormalities or anything that could possibly go wrong. This must be done at 72 inches. We want to have enough distance really to get all 7 vertebrae on there, but with the distance on there, it opens up the intervertebral disc spaces the best if you are a little bit further away from this. 8x10 cassette with collimation, your small focal spot. Expiration is key on this view. You do have to do this on expiration to bring the shoulders down as much as possible because that is going to be your greatest concern of getting all 7 vertebrae on there. The CR to C4, use the EAM as a landmark, so the little kind of hole, your little ear hole on there. Nothing is going to be above that, so you can use that as a top line reference on there. Perpendicular tube, so no tube angle on this. Weights, when necessary, depending, you will have to adjust based on how thick the shoulders are from patient to patient. You must see all 7 vertebrae on there. You should see probably a third of the T1 vertebra as well on there, just to make sure that you get the space on that. Chin up, slightly extended on this as well. AP open mouth projection. This is an AP of C1 and C2. You're going to do a minimum of 40-inch distance, but you can do all of these at 72 inches. If you're a little bit shorter, it's going to be tough once you get to the obliques, so you can mix and match your distances as much as you would like. 8x10 cassette, suspended respiration, CR MSP, so mid-sagittal plane with the lower margin of the upper teeth aligned with the base of the skull. So as we look at our top teeth, we're going to align that with the base of the skull where we can find our mastoid processes. And we will show that to you in the lab assignment. 3x5 collimation, it's got to be a little bit wider than it is longer so that you can get the entire body of C2 on here that you can see here outlined. C1 is going to be this portion right here. It's going to be this kind of wedge-shaped bone going across here, and you should see the transverse processes come out towards the outside as well. This is just for C1 and C2. You're going to do this as a perpendicular tube in most cases, with some exceptions. Apiaxial, AP of C3 through C7, you need at least minimum 40 inches. Everything else is the same. You can just suspend respiration because we want to see the air holding still within the trachea, which sits just anterior to your vertebra. CR is going to be about C4 to C5. Tube angle, 15 degrees cephalad to match the disc spaces. Because the neck is a little bit curved, we are going to put a little bit of an angle on it to actually go through these spaces and open them up, the intervertebral disc spaces, as much as possible. This is going to conclude the first set of slides. We will have a second presentation to go over the rest of the C-spine.